It often takes the death of a celebrity for the world to talk about suicide. This month, TV chef Anthony Bourdain and designer Kate Spade took their lives. Globally, around 800,000 people kill themselves each year. But what drives people to take their own lives, and how should we tackle it as a society? This is Roundtable with me, Shuli Ghosh. According to the World Health Organization, global suicide rates declined over the past few years, but in some countries, like the US, it's on the rise. And it's thought for each adult who died, there may have been over 20 others trying to end their lives. So what makes people believe that death is the only answer?
It doesn't discriminate and can strike when least expected. Suicide claims almost 800,000 lives globally each year, far more men than women. People who suffer from mental health issues are often exposed to prejudice and intolerance. But is mental health the only cause? What can be done to help those who need it most? Often it takes a high-profile death to bring attention to the suffering. In June, fashion designer Kate Spade and TV chef Anthony Bourdain took their own lives.
I think this one was a real surprise to everyone. I've spoken to some of his friends and they said that he has said lately that he's the happiest he's ever been. So I don't think this was really expected.
Around the world, one person commits suicide every 40 seconds and many more attempt it. The World Health Organization predicts that by 2020, that will increase to 1 every 20 seconds. It's the second biggest cause of death among 15 to 29-year-olds globally. Across America, the suicide rate rose by 30% between 2000 and 2016. The tragic and very public deaths of Spade and Bourdain saw a 65% spike in calls and texts to crisis centres.
People aren't necessarily going to reach out themselves. We have to keep reaching out to each other to check in and make sure that we're all okay.
How does increased coverage and discussion around suicide and mental health affect the numbers? The link between suicide and mental disorders has been established in high-income countries, although many deaths happen impulsively in moments of crisis. Inequality, conflict, disaster, violence, abuse, loss or isolation are all thought to influence suicidal behaviour. New Zealand ranks number 8 in the happiness index, but it hides a dark secret. In 2017, the suicide rate of teenagers between 15 and 19 was the highest out of 41 OECD and EU countries. There are concerns media coverage raises the risk of copycats. In over 2 years in the Welsh town of Bridgend, 23 young people committed suicide. Confused and worried locals said media reports glamorised suicide. In the UK, there was a 3.6% fall in the suicide rate from 2015 to 16, the largest decrease in 20 years. The World Health Organization recognises suicide as a public health priority and is supporting countries to develop their own strategy. But have governments waited too long to invest in prevention and research? How can we turn the tragedy of suicide into hope?
Well, joining us from Geneva is Alexandra Fleischmann, a scientist from the Department of Mental Health and Substance Abuse at the World Health Organization. She leads their suicide prevention strategy. In the studio is Marjorie Wallace, the founder and chief executive of mental health charity Sane. Jessica Anderson, who's had personal experience with suicidal feelings, and Caroline Hocking, a clinical psychologist. Good to have all of you ladies here with me today. Jessica, let me start with you because it's a difficult subject to talk about. Are you able to explain why you felt that suicide was the only option to the problems that you had?
It was an overwhelming feeling of hopelessness that resulted in my suicide attempts. Coming to the realisation that people would be better off without you there, that you didn't serve any purpose in life. I was in unstable employment at the time, which I feel heavily contributed. I was at a stage of my life where I just saw myself going nowhere. Almost.
But, you know, people looking at you, and I suppose this is one of the problems, people looking at you would say, you're attractive, you're smart, you're articulate. How could you possibly have so many problems that you wanted to end it all?
Well, I've got bipolar disorder and I'm on medication
Right.
to maintain a well mental state with that. And it's chemical in the brain, and that's the misconception that a lot of people have, is that you look well. In fact, often the better I look, the worse I am inside, because you're putting that mask on so people don't come up to you and go, oh, what's wrong? And when I'm looking a bit grubby and I haven't bothered to wash my hair for a little while, I'm often at my happiest, because I don't mind if people query things then. But it's easy with mental health to cover things up, and that's the thing. It's an invisible illness. People don't see it, and that's why they don't understand, because during my times of crisis, I would have doctors say to me, oh, you look fine, and I'd say, no, I'm slipping into a depression. I've got years of experience of this. I know, please help me. And they just wouldn't know what to do. They'd say, well, when you get to that stage when you want to commit suicide, just go to hospital. I heard that from my doctor 3 weeks before my last suicide attempt, and I just lost faith in the services at that stage.
It's extraordinary. I mean, Marjorie, I presume this is a similar experience. Jessica says it's an invisible illness. Often a lot of people who are deeply unhappy do put a mask on their feelings.
Yes, absolutely. I mean, you can't tell somebody, because they are going to not tell their inner feelings. So we've got a campaign at the moment, which is, you know, depression doesn't want you to talk about it, but we do. And we receive calls to our helpline, Sane line. And 2/3 of those calls, well, just under 2/3, are from people who have suicidal thoughts and feelings. And mainly what they're doing is they're not necessarily a terrible point in their lives or things that you can imagine. We did an analysis, a 4-year analysis, of why people were felt that death was the only way out, the only option. And one of the factors that came up was that they're really weary of the daily battle of fighting their depression, fighting the inner demons, fighting the dark thoughts. And it was suicidal exhaustion was contributing to the fact that they felt they just had no energy to go on. So people need to look out, not just for a time when people are in acute stress or crisis. They need to look out for when they start to be withdrawn, when they are lacking in energy. It's cumulative
process.
And what we do find out, and all our research shows, is that intervention helps. It's not intervening is the worst thing you can do, because if you can intervene, you buy time. You literally buy time, because a person is not always determined to die, but if you can break that powerful downward spiral that their thoughts are going into, you distract them, you intervene, they give themselves a second chance. And so the person who's on the top of a roof, say they're on a bridge or something like that, they don't go on to the next high building if somebody intervenes. You've distracted them, you've taken them away from that one course of action. So people should intervene, and some research has shown that people seeing somebody distressed, just small talk can sometimes help.
It's quite a difficult subject to research, though, isn't it, Caroline? And there seem to be many factors involved. It's quite astonishing that figures show that suicide rates, although they've declined globally, have actually increased in America, and nobody really knows why, although we can guess as to what the factors might be.
Absolutely. I mean, I think we have to acknowledge there's been a significant cut in mental health spending, and that means less access to mental health treatment, particularly in the US. I also feel there's probably not enough in this country as well. There are a lot of people that aren't accessing really effective, really well validated with research, treatments that could improve their quality of life and dramatically reduce their suicide risk.
And Marjorie was saying intervention is a very important part of that. Reaching out, connecting with people, that seems to be one of the main things that we can do as a society to help people.
Absolutely. I think a huge factor is social isolation, for people, and a sense of not being understood, not feeling part of a community. So we can take that as an individual responsibility as well to reach out to people, ask how they're going. I totally agree with you, Marjorie. We do need to ask. You know, directly ask, are you thinking about suicide? Are you thinking about ending your life? It's a myth that would be, you know, planting a seed in somebody's mind.
Difficult question to ask. Alexandra, how worried is the WHO about suicide and the links with mental health issues?
Yeah, it's very important to talk about it, and it is a mental health issue. Of course, one important risk factor is to have a mental disorder or alcohol use disorder, but equally important are different stressors in life. It could be a loss of work, loss of a relationship, or the fight with a partner. It could be bullying at school, or any other stressful situation. And so this is the moment where the person is not identified or diagnosed with a mental disorder, but it's still a mental health issue. It's still that you have a problem carrying, that you're carrying with you, and it's something you have to address. And this is why also problem solving is very important as an intervention, as much as follow up with the person and to keep the contact. Because we've heard before that social isolation is also a risk factor. So here, it is important to keep the contact with the person.
Do you think it's easy to talk about mental health issues? Do we as a society, you know, is there a stigma attached? Are we embarrassed?
It's a lot better than it was, because when I founded the charity Sane 30 years ago, nobody spoke up. Everyone would have to have false names if they went in the papers. They were photographed in the shadows. We do talk about it. The trouble is that when we do talk about it, then where do people go and get help? Everybody then feels helpless because, as Caroline's saying, the mental health services are so denuded at the moment. People turning up at accident and emergency, they've tried to attempt suicide, and I think Jessica's had that experience. That two out of 5 get no follow-up from the mental health services. I mean, this is crazy. It's just like somebody's declared that they could be in danger of taking their lives and nobody does anything. And that's the problem. It's all very well talking about it. We need to have people there to respond immediately and to be able to give people the therapy, the counselling, and the knowledge that they can be safe somewhere. And we've destroyed all these places of safety. Very few places have crisis beds.
Money has obviously got a big part to play in this. I've got a friend who's bipolar. She had a lot more support 20, 30 years ago than she does now. Now it's all about having her benefits reassessed, and various drop-in centres are closing down. So is this not a priority for our health service, and should it be a priority?
It certainly should be, absolutely. What we know is that it won't get better without intervention, without treatment. Mental health simply won't improve. In fact, you know, their life will crumble effectively in many cases. So we really need to offer this support, because it's the impact not just on the individual, but also on their family as well, on their children, and then it can go on for generations and generations.
Is there still this feeling that you should be able to just pull yourself together and deal with it on your own, that it's not seen in the same category as a physical illness? Did you find that when you were suffering?
Absolutely, 100%. With it being invisible, that's the hardest barrier you have to face. And also people bring their own personal views towards it, that because they're mentally well, they can't understand why you're not mentally well, and they can't understand why you need medication to help what is in fact a brain illness, whereas you wouldn't say to someone with diabetes, oh, your pancreas will pull itself together. As with mental health, they seem to think you can somehow override it, when all you need is that sometimes a bit of medication, a bit of therapy, various things. It's trial and error. And with mental health, it's difficult because you don't have tangible things like blood test results, scans to show what's what. That's why it can be an uphill struggle and can take years to finally plateau on the right therapy, which is right for you. But there is hope out there, because even though it took me about 5 years to get the right combination. Once you get there, it's amazing.
Then it makes a huge difference.
Yeah.
Alexandra, I know that there are in the US the suicide rate has gone up, and one of the key factors we think is addiction, alcoholism, drug addiction. That's also something that your department concentrates on. And in America, of course, there is an opioid crisis which is being seen as an epidemic. How much is that contributing to the spike in suicides?
Yeah, certainly alcohol is a risk factor. Alcohol use disorder is a risk factor in suicides, and it's estimated to about 1/5 of suicides wouldn't be there if there weren't alcohol. So, and the same is, of course, with drugs like opioids, that their use or dependence is a risk factor for suicide.
So therefore, does it follow
it's
that
complex? Usually, there's
if
not
there was
just
more
one.
intervention to tackle drug addiction and alcohol addiction, do you think that would have a knock-on effect on suicide rates?
Yes, certainly. Yeah, investments are needed into training, into capacity building of health workers, specialized health worker, non-specialized health worker, community health worker, exactly with regard to the topic that was addressed before, that when people are seeking help, that they actually receive the help they need and the most appropriate help they need. So they shouldn't be turned away from the health service. And that's true for mental disorders, but it's as much true for alcohol use disorders or substance use disorders.
So it seems from what Alexandra is saying, there are a number of factors which could be tackled. So we need a multi-sectoral approach.
But it's not huge resources that we're really talking about. A lot of it is just common sense and feeling. We have a legacy of blame and shame. You know, it's only since the 60s that it was decriminalised, that suicide was actually considered a crime. And we still have this legacy that somehow or other, either the person's to blame and shame or the family's to blame and shame. And that's what we've got to look at. But what we haven't talked about is who are these people committing suicide? Now, in this country, 75% of all suicides are men. And of that, the group that's at the highest risk now, and this is rising, are men between the ages of 35 and 49, middle-aged men at the what do you think, the cusp of their careers, when they're having their young families, and they are the ones who are most likely, are most at risk of taking their lives.
Is that because women are better at communicating? Do women say how they're feeling?
I think the methods women often use to take their lives are ones that don't always result in fatality. I don't know if I'm correct in saying, but men are more likely to jump, hang, use methods like that, whereas women overdose more.
I was reading a horrible statistic that said in high gun ownership states in America, there were more male suicides that way.
Yes, any violent method, men are more likely to do, but except women are now coming up in the same way. This is awful what we're finding. In this epidemic we have of self-harm, which sometimes goes over into attempted suicide. Women are using the same more brutal ways, like hanging. Hanging is the way most people do commit suicide, and this is very worrying.
Access to means, access to means is an important risk factor, because it's not only firearms. In other parts of the world, it's access to pesticides, and there you have very high rates of suicide, also among women, where it's sometimes almost equally as high as men when you have readily and easy access to pesticides.
So, Alexandra, the World Health Organization is obviously working with countries to try and put prevention strategies in place. Are governments seeing this as a priority?
So since 2000, many countries have adopted at the government level such national strategies. And in the past 5 years, we have seen a further increase. So that's very important, because, as we said, it's a multi-sectoral issue, and you really have to work together, not only from the health sector, but also non-health sector, education for our young people, with law enforcement, with agriculture, for instance, with the media, of course. So in order to do this, it's important to have such a national comprehensive strategy. But the next most important thing is its implementation. So it's not enough to have a written document. It's important to put funding into it, to allocate the necessary resources, and to have these plans and strategies implemented, evaluated, revised to improve the results. So that's the challenge, but there are more and more countries.
I mean, national strategies are one part of it, but as you were saying, Marjorie, it's also about getting people to talk about it and becoming socially aware about the issues. I'm wondering whether young people, whether there's more of a risk amongst you were talking about social isolation, which is strange when you consider how many young people spend so much time on social media.
Yes, I think social media can be a bit double-edged though. I mean, on the one hand, it can be a great way to stay in contact with people, but I think when it's replacing, regular social contact, then perhaps it's not quite so helpful.
Does regular social contact, does that make a difference? Are we missing out on the things we used to do in past times of, I don't know, big family gatherings or social events where everybody got together? Is that one of the problems?
I think so. I think a sense of community is really important, actually, and a sense of social support. And maybe we don't get the same levels of oxytocin through social media that we would get through meeting up with a person face-to-face.
Yeah, so these virtual friends, this is what we find with young people. They have an awful lot of these people that they think are their friends, virtual friends. And then when it comes to there is quite an epidemic of loneliness amongst young people in this country, and depression. A recent survey showed this. And the fact is that they're not turning to the normal human contact. They're not trusting to teachers, and not trusting into friends in the way that we did in the past. And it's really, really sad to see how the social media has made people much more competitive, much more defensive about their lives, and less of the reality of the fact that life has its ups and downs, its highs and its lows, which people around you then tolerate. And I'm sure that's what people.
What about the issue of, there are some things we cannot change that people have to deal with. Poverty is one big thing. Disasters. I did a show on the aftermath of the hurricane at Puerto Rico, and one of the guests we had on the show said what was striking was the spike in suicides in the months following that disaster, because there'd been this huge event in their lives which they had no control over. So things like that are quite hard to take account of, aren't they, when it comes to suicidal feelings?
I think trauma is a huge factor actually in suicidal risk, but there is also very effective treatments for post-traumatic stress disorder and other trauma symptoms. So again, with appropriate counselling and appropriate help, there's a lot that can be done about people suffering from trauma.
And also common sense. We absolutely know that the most dangerous time for someone with mental illness is in the first 24 hours when they're discharged from hospital or leave with counselling or treatment. I mean, they're 10 times more likely to take their life. And yet you can't believe it. Just the insanity of our systems is that often the crisis team that's supposed to follow them don't arrive for 2 to 3 days, knowing that this is the critical period. Now, that shouldn't take, this just takes thinking about it and planning. It doesn't take any more or less resources. But if we don't stop people at that point, what else can we do? We know certain things, and we're not taking those steps.
So it's
and
the
other countries need to learn from the research. We've done a lot of research in this country, and if they could just learn from it, just implement it. Just don't let somebody walk out of a hospital and go back to a house alone, or a family, or a hotel, or wherever they're going. Don't let that happen. There's just sort of almost little golden rules that you should follow. So it makes them so frustrated that these deaths are happening.
That we know what works,
and you hear
yet
about
they're
these terrible
being
deaths
put in place.
that could have been prevented. And you meet heartbroken families, which I do all the time, and they could have been prevented. One person had just taken an action and just taken some pastoral care of a person.
What about making this easier to talk about? I mean, for example, do employers know enough? Can they spot it?
No. I've had terrible experiences with employers where I always believe it's better to be upfront, honest, talking about it, because the best time to talk to someone with a mental health someone with a mental health condition is when they're in their well stage, to say, look, this is the action plan for if I do slip, if I do feel my symptoms are going one way or the other. And employers, if they're not open to making reasonable adjustments in the workplace, which they are bound by law to do, but they don't.
I mean, they would have to if you had a disability or if you had a physical illness. But it seems that mental health is treated as something different.
Yes, like with one employer, when I asked for a very reasonable adjustment to be made, something that I'd looked into, and I said, look, you're more than able to make this adjustment. They said to me, oh, but then everyone will want this too. And I said, but not. It's like saying to a wheelchair user, oh, everyone will want a ramp now, you've asked for this. It's like, no, not everyone has a long-term condition that is covered under the Equality Act that you are bound by law to make adjustments for. But they were reluctant to do.
Overall, are things changing? Are we moving in the right direction?
I think we are slowly.
Certainly,
but more can be done.
and certainly today we know what works, and I fully agree with the other speakers. We know what works. There's evidence, and it's really about implementing what we know. And it's not only to work with the leadership from governments; it's also to work in communities. And like you said, it's different settings. It's in schools, it's in workplaces, it's in spare time activity settings. So we all have a role to play, and really the time to act is now, and there are things we can do.
The time to act is now. Thank you very much indeed to all my guests. A really interesting discussion and quite eye-opening. And if you do feel that you need to talk to someone, please go to the website suicide.org, which gives a list of international hotlines. Talking about it is the best thing to do. Thank you very much again, and thank you for watching at home. Until next time, bye for now.